Okay, like I said, good afternoon or good morning, depending on where you are. Thank you for joining us today. We're going to be talking today about virtual OSVs. Before we get into any substance, so just to anticipate what's going to come up, yes, we are going to send out the slides and a recording of the video to everybody, so you don't have to be sitting there with your camera and taking pictures of the screen. We are going to try to cover today both new things that are based on virtual and also sort of walk through each of the elements that apply and be able to give you some tips for each of the elements. If you have questions as we go along, please put them into the question and answer box. We will try to get to them at the end. If we don't get to them at the end, then we will respond to you after this. Okay, so with that, virtual OSVs. So as you all know, right, starting in COVID, that everyone stopped going out of the homes for a long time, and the OSVs, right, the reviewers stopped coming as well. I want to say that for most of 2020, I don't think there were OSVs. I think in 2021, they started them back up again, and they started doing them virtually. As we will talk about today, there are some benefits to the virtual, and there are some pitfalls that go with it. I would say that the reviews have become a little bit more difficult with virtual. We have heard from the reviewers that they believe that HRSA is never going back to in-person reviews and that they are going to be virtual. And we're going to talk to you today about actually a new beta test that HRSA is trying to do where it's involving only a one-day OSV. So what's changed significantly at a high level, right? So if you think about what used to happen, right? So if you've been through an OSV before, right, typically it's a 3-day process, right? It's really the bulk of 2 days, and the third day is just sort of, where they give you the exit conference and give you their findings. But normally what would happen is there would be a lot of time during the first day at least where you would sort of sit and, talk to them and schmooze with them and get to know each other, and there would be a lot of, I don't want to call it wasted time, but be a lot of time that was filled with, things other than substantive reviews. And so the time they spent on substantive reviews was significantly decreased from the amount of time, or significantly less than the amount of time they actually were on site. Plus, because they were normally traveling from wherever, usually when they came, they had not yet reviewed any of your documents, and so they spent a significant part of those 2 days reading the documents for the first time, which meant that because of that, they were not as prepared. They could not really be prepared. What's happened now is that because they are sitting at home, they are much more prepared, much better prepared. So in most OSVs, they are, by the time the OSV starts, they have reviewed all your documents and are coming in and asking you very specific and pointed questions. Now, the good thing about that is, if you've been through one before, they generally schedule, I'm making it up, for the first day in the afternoon, they'll schedule a quality assurance from 1 to 4 that day. And it used to be they took most of those 3 hours to talk to you. Now they might take only 20 minutes or a half an hour to talk to you, but during those 20 minutes, they don't want to hear what's in your policies. They've already read the policies. They're asking you very pointed questions, where in the past you could sort of, lose the detail within the forest. That's no longer the case. Now they've read through it and they're asking you much more difficult questions. So we found that you need to be much better prepared now than you used to be. And as we go through, we'll give you some examples of those. So the overall process is substantially similar in terms of there being a pre-visit conference call at least a couple of weeks before, and there being a list of documents that they want for you to give them. The difference is that now everything is done virtually, and so because of that, like I said, you lose some of the interpersonal and you run into a lot of technical problems, right? I don't know that I've been to, I should mention, this is one of the slides later, one of the good things about the virtual OSVs is that, at least for those of you who are clients, that in the past, we always tried to be part of the OSV and they would never allow attorneys to be part of it. Now, since the virtual ones, I think every single client we've worked with, they've allowed us to be part of it. So I have sat through, personally myself, 15 or 20 virtual OSVs, which is helpful because then when you're stuck on a question, I could jump in and sort of give you the answer. Whereas before, I sort of had to hide in the background and not be on, part of the meetings, and you have to walk out to ask me questions, which was much more difficult to do. But now we could actually be sitting in there and do that. But having sat through them, almost every single time there are some technical problems, right? Someone's camera goes out because the reviewers are sitting in 3 separate places, plus you have the HRSA representative, plus you have you, so you have at least 5 different sites where people are coming in through their platform, which, by the way, you cannot use your own platform. I believe they use GoToMeeting. I want to say it's GoToMeeting, and I will just tell you on a technical basis, we found very often that your IT department blocks access to that website, so to that system. So you want to make sure before they come on site that you're ready to do it, and you're not scrambling and not being able to get on. But in any case, if you're used to using Zoom or Teams or anything like that, you cannot. You have to use their system. So they require you to give the documents at least 2 weeks in advance. Like anything else, that 2 weeks in advance is not a hard and fast deadline. It is basically they would really want the documents by a week before, and they will allow you to give documents up to the end of the first day of the OSV. And there's a cutoff at 5 o'clock on the end of the first day. If you have nice reviewers, and we've seen this pretty often, what they'll do is on the first day they will ask you all the questions that relate to things needing documents, but after so that you could provide it, but otherwise, like I said, the end of the first day is it, and they will not let you do things on the second day. They also, if for those of you who have not had one in a while, it used to be that while you're on site, if they found some, small problems in a policy, they would let you fix it. They pretty much have done away with that, and they do not let you fix things anymore. It's only about the question of finding, right? If they're asking you for minutes where the board approved the sliding fee categories and looked at data to be able to prove that, the $25 you charge as a minimal fee is not too excessive for patients, and you hadn't previously provided, they'll let you go find the minutes and give it to them. They will not let you go and amend documents. I know that I'm jumping around a little bit, but for those of you who listened to me before, I have a very hard time following the script. So the OSV, it's the same general structure as it used to be, right? You have the first hour where they do an introduction, you do an introduction. They are going to do virtual site tours of at least 2 sites. Now, one of the problems that comes up with a virtual site tour, right, is before, when you did a site tour, you were sort of in control, right? Here it becomes more difficult because, number one, you have to do this on, like an iPhone or you're on an iPad walking around, and you should have 2 people prepared for it, one person holding the iPad and the other person is actually able to talk and show them everything. But they are looking for a lot of different things, and they are stopping people, as you're walking through the hallway, saying, can you stop? I want to ask that person a question. So I'll give you a free tip. You need to make sure when you're doing those virtual tours that if you have staff who you are concerned about what they might say, that you send them out for a lunch break, a smoke break, or whatever it is, tell them to take the day off, because we have seen them randomly ask you to stop random people and ask questions to them. I don't mean patients, I mean staff members. So you want to make sure you have some staff there, so it doesn't look like the center is empty, but you want to make sure the staff you have are people who are prepared to answer questions. Excuse me. Okay, so the tour includes both interior and exterior. Like, they want you to start outside, and they want to see the door, and they want to see everything, and they stop you. They want to see sliding fee signage and all the other signage that required. They're actually looking for you to be able to show it to them and show them where, your soiled room is, and show them the refrigerator where you keep your vaccines and things like that. And so there's, a big focus on all of that. Okay. You may have to share your screen at some point, so they may be able to, they may want to share their screen, so you need to be prepared for that. The other thing is that we've seen, and this really depends on the reviewers, in some of the OSVs, virtual OSVs, they are allowing everyone to sit in a room together, or if you have 3 people participating in a session, 3 people together. In other ones, they want each person to be sitting in a different room. Now, that still means you could have 3 people on together, but now when you're sitting in a different room, that sort of takes away your ability to, with hand motions and whisper to each other and do those things. So again, it makes it a little bit more difficult to be prepared for it. I know you could be texting each other, but that's a little bit harder when you're supposed to be looking at the screen. Okay, so like I said, it's really important that you be prepared, because when you have a policy, right, if you take the average person, average senior management person in FQHC that has a policy, right, your policy on risk management, it might be 6 pages long, and you've never actually, you sat and read word for word, and they may be asking you very detailed questions about it. So you need to have people who are knowledgeable about what's in your policy or knowledgeable generally about policies, right? As I mentioned, having sat through them, I have found very often that I'm answering questions because no one else, because sort of we write the policy so we know what's in them, but they're asking very detailed questions that people who are very experienced and have done this many times are not able to answer. I'm just seeing as we're talking, so I have a question popping up. Generally, the notice for a virtual OSV is similar to the other notice. We have seen that they generally try to give you around 2 months notice. I would say we've seen someplace between 6 weeks and 3 months as sort of the spread for when people have gotten notice of the OSV. Also very important when you get notice is to start preparing right away, and I would tell you that we're going to go through some of the details, but Form 5A is the thing you need to work on first, because if you need to do a change of scope can take some time. I will say that whereas it used to take 60 days, nowadays we're seeing them happen pretty quickly. I would say an average of 15 days. Don't wait till only 15 days before to do it, but I would say it's an average, and almost every place we go, you need to make some changes to Form 5A because HRSA has changed how they define some of the categories, as Emily will talk about in a few minutes. So that's the first thing I would start with. Also, because you may need to amend your contract for column 2 and column 3. Again, there is new language that needs to be in there. So I'm going to tell you right now that if you have not updated your Form 5A in 2 or 3 years, and you haven't updated your column 2 and column 3 contracts in the last couple of years, then I feel very comfortable that just about anyone who's on this phone now will have to go back and make significant change, have to change a significant number of contracts. The changes are not significant, but there's specific wording that HRSA requires that will now need to be added to it. So you want to jump on that first. Okay, so the new model. One of our clients is actually having an OSV in about a month from now, and HRSA is beta testing a new model on them. This model consists of reviewing 14 out of the 18 elements in advance of the OSV. So basically, they want to submit all the stuff, and then they review it in advance, and then they're going to spend only 1 day on site reviewing 3 or 4 elements. Right, those elements include things like sliding fee scale. It's sort of the things where they have to ask you questions rather than being able to review documents. But basically, anything where they can review documents, they want to do this in advance. Again, in my head, we're going to be part of it, so I will probably be able to report back to you by the end of July as to how it went. But in my head, this is not something that's beneficial. I understand it's beneficial for HRSA, and they save themselves time and money paying all the reviewers. It's not necessarily beneficial for you, because now when they're reviewing the policy and they don't understand something or they find a problem in it, you're not there to have an interaction with them, right? So now normally what's been happening in the virtual ones is during the review, they'll say, I read your sliding fee policy, I don't really understand here. How are you doing this? How are you doing that? And you could have a conversation with them and go back and forth and explain, well, the thing you're looking for may not be in the QA policy, but it may be in the risk management policy. If they're reviewing it all by themselves, you lose the opportunity to do it, which means that each of your policies needs to be even more perfect because you don't have the ability to reference a different policy because you're not there with them to have the interaction. It's easier for you in the sense that it's only one day instead of 2 or 3, but like I say, I think, not having sat through it yet, but I feel like it's going to be more difficult to get a good score on this. Right, as in the past, I should talk about scores for a second. As in the past, the scoring, right, they now have, I believe, 94 elements that they, consider part of it, and it's either pass, fail on each of the 94. And so when if they find a problem, you'll potentially have, let me put it this way. It's very difficult to achieve, a perfect score. We have had many clients that have done very well, which we'll talk about a little bit later. But, each of the elements, right? So if you could have, 6 wrong out of 94, but each one of those 6 is in a different chapter. And so then at the end, they're going to tell you you've failed 6 chapters, even though you only failed a small subset of it. The rest of the process is substantially similar. If, the last day they give you, at the end of each day, they give you sort of what have we found so far today. The last day they give you an exit conference. Then you have some time until they prepare the report. Then you have to prepare the report. You have to submit your corrective action or done things, and you normally would prepare that in advance of getting the report because you know what they're going to talk about. So with that, I'm going to turn it over to Emily to walk through each of the items and sort of some tips on those items.
Thank you. Okay, so I'm going to give kind of a high-level overview of each of the items. Many of these items can be a webinar in and of itself, so I'm not going to be able to give so many details. But what we'll try to do is point out where things have been changing, certainly in light of the virtual nature of the visit now. And some of this stuff is kind of what's been changing since the compliance manual came out in 2018. So we'll go over that together. So the first element is about the needs assessment. Every center does a needs assessment with their application, and then they have to do it again with their reapplication. So it used to be that the reviewers would only look at what you did with your original application or your reapproval, and that would be enough. Now what they're looking for is to see a lot more involvement from the board on the kind of day-to-day operations of the health center. How are you being responsive to the patient needs? How are you knowing what the patient is needing, the patient population is needing? So they're going to be looking through the minutes in a lot more detail and trying to find, how are you responding to what has changed? So one example we can give you is the whole landscape of healthcare changed with the COVID pandemic, and what did you do in response to that? How was your board involved in any action that you took? How was it reflected in the minutes? Everything like that.
Right, so just to add to that, if all you have on need is your needs assessment that you did 3 years ago, you're not going to pass. Like Emily just said, you need to be able to demonstrate things that were done based on patient needs. Now, that could be changing hours, it could be adding telemedicine, things like that. And it's not just that you did it as a health center, it's that you did it and the board, there's some discussion in the board minutes about it. If you don't have that, you have an OSV coming up, speak to us separately and we'll give you some tips for that.
Another point is that the board has to actively approve the zip codes that are in the service area. So you should actually, a tip for you is to list out all of the zip codes that you're including in your service area, literally stick it in front of the board and have the board pass a motion approving those to make sure that you have it documented somewhere that the board was involved in that approval. Okay, the next topic is required and additional health services. This is essentially forms 5A, 5B, and 5C. And as Jeff mentioned before, this is pretty much the first thing that you should start with when you find out that you're going to have an OSV, because it's the most lead time for fixing. So again, it can technically take up to 60 days. Now, as Jeff said, we're seeing it be shorter, but this is, something that every single client that we interact with, they have changes, there are corrections that need to be made. In part, it's because of just, day-to-day, your services that you're providing are being changed, and then also HRSA's constantly changing, their requirements and their rules. And it's also not something that's necessarily consistent over time. So I'll give an example, which is that let's say you have a podiatrist or a social worker who's coming on site and providing services. They're not a W-2 employee, but they're a 1099 contracted employee, and they're providing them on site. It used to be that because they were on site, they would go into column 1, but HRSA has determined over the past few years that no, actually it should go in column 2 because they are a 1099 and not directly employed. So that's something that we have had to change with a lot of clients. Also, there are technically, you have so let's say you have a bunch of column 3 agreements that you send out. So for example, let's say for a lab you use BioReference, Quest, and a private lab. It used to be you would have to show every single agreement that you had contracted out, but now you only have to show one agreement. So a practical tip for you is that pick the one that you use the most or that you know is the most compliant agreement, and that's the one that you should focus your conversation on and show to HRSA, because you don't have to show all of them. The problem arises when you start speaking about other labs that you contract with. The moment that you mention it, then HRSA can say, okay, so let's see that agreement and we'll check if you're in compliance with all the language that you need, and then you're going to need to show it to them. So focus your conversation, pick the one that you feel most comfortable with, and then just remember that you only need to show one agreement per column.
Right, and just another thing about this is, for those of you who have dealt with these contracts, right, column 2 agreements needed to have more language in column 3 agreements, and now HRSA essentially is requiring the column 2 language in the column 3 agreements as well. If you don't know what that means, then you should reach out to us separately and we'll explain it. Also, just to clarify something that was said a couple of minutes ago, when we talked about the board being involved in day-to-day, we didn't mean the board should be involved in day-to-day running operations of the center. What we meant is that the day-to-day issues that come up relating to need, right? So it doesn't mean on a Tuesday something happens, you call the board, but it means that if we've determined based on need that we're going to make changes to things that involve day-to-day operations, the board has to approve it. Like I said, telehealth being an example.
Right, and on that note about the contracts needed updating the language, so that's something that we spend a lot of time on and also takes time in addition to fixing your Form 5A is the correspondence back and forth between your contracted, between your contracts. So you have to add in this language, and in some contexts it doesn't actually make sense to have some of this language, and it's a very fun conversation to get on the phone and say, we need to put this language in, and they say, well, it doesn't make any sense, we don't want it, and we say, we know, we agree with you, but HRSA doesn't agree, so if we're going to have this contract, we need to have this language. So that's one of the perks of having an attorney help you out, whether it's us or not, is that you have to get on these calls with these, let's say, for example, a language interpreter company who doesn't really make sense to talk about credentialing and things like that, but that language still does need to be in there. So it's very important to go back to your agreements and to check that you have the updated language, and it's very specific. We like to call it magic HRSA language, because even a slight difference in the language, like Charlie went to the store versus Charlie visited the store, could make you in or out of compliance.
Yes, I was starting to get a number of questions. Historically, we don't finish on time, so at this point, I think please put your questions in, but we're going to leave them to the end to make sure that we have time to be able to address all the substantive issues.
One last thing I want to point out is with regard to additional services, a lot of times we have clients who kind of panic because they used to provide an additional service and now they don't, so they're trying to scramble and find a contract with someone to provide that service. Additional service is not required. It just is, if you have additional services, you put it on your Form 5A for terms of just showing what your services are and FTCA and things like that. But if you no longer provide the service, then you can just take it off Form 5A and you don't need to scramble to find a replacement. Okay, clinical staffing. So there used to be a requirement that the majority of your clinical staff had to be directly employed. That's no longer the case. Obviously, you do want many of your providers to be directly employed, but the most thing that's being focused on when it comes to clinical staffing is credentialing and privileging. And I would say that after Forms 5A, 5B, and 5C, this is the topic that is most dinged on or credit is taken off of, because it's really highly specific. There's a lot of details that go into it. You want to make sure that your files have every single piece of paper that it's supposed to have, that you're assessing correctly for fitness of duty and competence, things like that. So, one example that we come across fairly often is that you have an FQHC that just copied, they used to work with a hospital, so they just copied the privileging forms of the hospital, but that doesn't actually make sense in the context of an FQHC. So you want to make sure that your forms make sense, that your files are being updated regularly, and that you are credentialing correctly for the type of provider that is being presented. So, for example, just generally I want to mention that the people who need to be credentialed and privileged are anyone who is essentially touching the patient, and that will include nurses, medical assistants, even though under state law you don't have to credential a medical assistant. For FQHC purposes, you do. And then in addition to just touching the patient, if you think in the context of like a social worker who's not necessarily going to, but they're providing direct clinical services, so they have to be credentialed as well.
Right, and just to add one more point to that, so if you go back and look at the manual, it still seems to talk about that you could decide for yourself how many people on site are going to be BLS, but HRSA has been taking the position recently that anyone who falls into the credentialing package, right, that including OCSs, needs to have BLS.
Another point is for verification of clinical competence, you can decide how that's being done. So that can, let's say you have a provider who's been working for the FQHC for 10 years, so you can just use peer review to show that they are clinically competent. One thing to note is that if you are contracting providers from a different entity, such as a hospital, and the hospital themselves are credentialing those providers, then you can rely on the hospital's credentialing. You don't have to perform it yourself. However, you do have to make sure that whatever agreement you have with the hospital for those providers will include the special magic HRSA language saying that they credential and privilege them in accordance with, the FQHC requirements. Okay. Accessible locations and hours of operations. You want to make sure that your locations and your hours of operations are appropriately serving your patient population. So a lot of what HRSA was looking for was availability of evening and weekend hours, depending, of course, on where your FQHC is located and what your population needs. A problem that we run into a lot is that COVID has affected staffing, and so a lot of FQHCs had to cut down on their maybe weekend hours or night hours. And so our response to this issue has been to make sure you have a kind of robust conversation about it with the board and reflect that in the minutes to demonstrate that, this is an issue and this is the reason why we've had to cut down. This is our plan for remedying it in the future and kind of our timeline for when we expect to go back to normal hours. They also want to see how you're assessing that you're accessible, and you could do that in a number of ways. That could include, a patient survey. You can get feedback from your patient board members. You can use your QA data, pull data from that, and just make sure that you're reporting it to the board and you have it reflected in the minutes.
Okay, just like a throwaway on that becomes really important is, so if using the example Emily just said, if you cut down your weekend hours, you cut down your evening hours, your Form 5B probably reflects your old hours before you cut it down, and so that's just like a stupid thing to get cited for because you have the wrong number of hours listed on Form 5B.
So the next topic is coverage for medical emergencies during and after hours. I would assume most health centers have already come across this, but it used to be that the coverage only discussed after hours. Now it also focuses on coverage during hours. So what that means is if someone walks into your health center and collapses right there in the patient waiting room, what is your response to that? So a lot of FQHCs will say, oh, we have, code blue, code red, this is what happens, and that's good, and it's good to have a process, but you also have to make sure that it's covered in a written coverage during hours plan. We have forms for all of that, so we can help you with that if you don't have it. Another thing that comes up is if you have someone who's walking in with like an infectious disease, obviously COVID is the hot topic. How are you reacting if someone comes in coughing all over the place, and Are you having a separate waiting room for them? Are you asking them to step outside? This is all something that should be reflected within your written plan. Also, Jeff mentioned before, you need to have someone who is certified in BLS at each approved site for any time that that site is open. So that might seem fairly obvious. You're going to tell me, I have a doctor, I have a nurse at every single site, but where this might come up is, let's say you only provide behavioral health, 1 hour on a Sunday. That behavioral health provider might not be certified in BLS. So that's something to think about and consider when you have those kind of additional services. Okay, another important part of coverage is the after-hours coverage. You want to make sure that you have an answering service who is able to answer calls that you're getting after hours, as well as having a provider on call who can then address those issues as they emerge. The patients need to be notified of the fact that there is after-hour coverage. So most FQHCs have this on their website saying we have, 24/7 answering service, everything like that. It's, not enough to just have it in your new patient brochure saying that we have, 24/7 coverage, because if you have a patient who's been there for 30 years, obviously they're never looking at the patient brochure they were handed, 30 years ago. So you want to make sure either you have it in patient areas or on your website you determine how you should notify patients, but they do need to be aware of this. A tip is that these reviewers actually will go after hours and they'll call up your answering service and see how the calls are handled. So you kind of might want to practice a run through and see how efficient it is, and see that the call is being rolled over from all numbers. So a lot of times we'll see that the main telephone number that you call will get rolled over to the answering service, but then you have specific, if you want to speak to the pediatrician, dial 1, and then it just goes nowhere. So you want to make sure that all those incidental lines are also being rolled over to the answering service, and that you're getting, a log of whatever calls you got, that those calls are being followed up with, and that they're being addressed the following day or, within that hour, depending on how emergent it is.
Right, and just on that point, not only they will call, I think every single time they will call the answering service after hours, and they will test it against your policy. Your policy says the doctor has to respond within 30 minutes. They're going to test to see whether you actually did respond within 30 minutes. Right, so we just had an OSV where the medical director decided to be the one on call that night just to deal with this, and HRSA waited until like 7:30 in the morning, and he basically stayed up the whole night trying to be ready for it, and 7:30 in the morning he fell asleep. And luckily he got back to them at the 27-minute mark when the policy said 30 minutes. But they said if he had waited 4 more minutes, they would have failed him on it.
Something I neglected to mention when we were talking about the required services is that you need to have a language interpreting service, and so that also applies to your after-hours coverage. You need to make sure that if somebody is calling and speaking a different language than English after hours, that there is some availability, at least for the main languages that are spoken in the FQHC, to communicate with that person even after hours. And then just on that note, you want to make sure that your language provider is listed on your column 2. You want to make sure that you have a referral agreement for that. And then this kind of just speaks more to FTCA and risk management, but you just want to make sure that even when patients are within the clinic itself, you are using either your clinical staff or your language interpreting service to speak to patients. It's really, from a risk management perspective, never a good idea to use the family member, because even if they're proficient in, for example, English and Spanish, it doesn't necessarily mean that they're proficient in medical terminology. So it's a very big risk management issue. You want to make sure you're using either a qualified clinical person from the FQHC, or you're calling, your language service provider. And then from an ADA perspective, obviously you also need to be concerned about someone who is, hearing impaired, and they have now these apps where everything could be done on video, and you could do it, the appointment virtually that way.
Right. This is not the subject of today's webinar, and maybe we'll do a separate webinar on this in the future, but just to point out, we are seeing more and more ADA-type claims against FQHCs, whether it relates to your website not being accessible for the blind, or it relates to your translation services for people who are deaf. I don't know why. We until like a year or two ago, we didn't see any of these cases, and now we're starting to see many of them. So So I would tell you that's something you need to consider. If you want to have a separate conversation, we're happy to do that with you.
Okay, continuity of care and hospital admitting essentially is that you need to have your doctors have access or like hospital admitting privileges to your patients. In most services, the doctor doesn't have that. That typically arises in like OBGYN. So the other option is to have some kind of arrangement with the hospital where they are able to cover your patients. So again, that just requires having an agreement and having the magic HRSA language. A big issue that goes hand in hand with this is also a risk management issue. It has to do with tracking. You need to be able to track the patients that you are sending into the FQHC. So long ago, it used to be that you needed to know every single time one of your patients were in the hospital, you would tell the hospital that you need to know it, and they would laugh at you and say that you're ridiculous because they're busy trying to run a hospital and can't tell you who's their patient, who's your patient. So thankfully, HRSA has changed it. It's easier now in terms of you only need to be aware of the patients that the FQHC is sending to the hospital, but it still is a pretty intense role. A lot of FQHCs have a designated role just in charge of tracking, hospitalization and making sure that those patients are coming back to the FQHC for continuity of care after.
Right, and HRSA generally will ask you for a log to be able to see. They'll pick a random day and say, give me a log of which of your patients that you had sent to the hospital or in the hospital and what was their status.
Yeah, and on that note, just practically, if a doctor is writing in his notes, I sent this patient to the hospital, that's not going anywhere. That's staying within the doctor's notes. So the doctor is going to need to create some sort of referral process where it can actually be tracked and put into a system that it can get entered onto that log. This is a little bit off topic, but it's kind of the same thing. We also have an obligation to do lab tracking. So, you send out a lab and then you want to have some sort of mechanism in place where you can track the results of those labs if they were reported to the patient. Something that's different with FQHCs and private practices is that you're not only reporting to the patient regarding abnormal results, but you also have to report to the patient regarding normal results. So as a patient, that obviously feels really great if your doctor calls you the next day and says, everything's fine, you don't have to worry, so that you don't have to sit until your next appointment and the doctor say, oh yeah, by the way, everything was fine, so you didn't have to worry for 3 weeks. So that's very comforting for a patient, but again, it can be time-consuming for the FQHC, so your policies need to address how you're reporting to the patient, how quickly you're reporting to the patient, what methods of communication you're using, and then of course for emergent or critical results, you need to have a system in place to pretty much notify the patient immediately. So if you can't directly reach the patient, then you might have to go to an authorized representative, and in case, very emergent cases, they even want you to call the police to be able to get a hold of the patient or something like that. And then the last tracking policy that you need and practices that you need is for referral tracking. So again, you refer your patient out to like a cardiologist or, podiatrist, any sort of specialist, and you need to actually follow up and make sure, did they go, did they see the doctor, and with what results. Okay. Sliding fee is a pretty massive topic. It can have its own webinar, so this is going to be super high level, but if you have any questions, feel free to send them and we can try to answer it. Essentially, sliding fee says that you need to give a discount to patients based on their income and family size, and it used to be patients would say, yeah, if you don't have insurance or if you're self-pay, that's who we give the discount to, but it doesn't only apply to self-pay patients, it also applies to someone who, let's say, has insurance but has a high deductible. So make sure that you're aware of that, and more importantly, the patient is aware of that, so you need to be notifying the patient through your website, through patient areas, however you want to notify them, they do need to be notified. And essentially it means that anyone who is below 100% can be charged no more than a nominal fee, and that anyone who is between 101% to 200% needs to have a discount applied. So one of the requirements is that you can't just say anyone above 101% will get a discount of 70%. You actually have to have 3 distinct categories between 100 and 200%, and you can set that up however you want. HRSA doesn't tell you what those categories need to be or what those discounts need to be. So you can have a flat rate, like someone in this category will have a $20 discount, or you can have a percentage mechanism. Someone in this category will have an 80% discount, something like that. something that has changed very much recently is that the reviewers are really getting very specific about seeing how the board was involved in the decision to create the scale and to come up with the numbers and to come up with the charges and how much it is actually being used, what utilization is. So on a technical level, this has to be reviewed once every 3 years, but on a practical level, when you update it for the federal poverty guidelines, it's reviewed every year. So they want to see conversation and data that was presented to the board actually reflected in the minutes showing, how many of our patients are using the scale, what categories are they falling into, how did we arrive at our nominal fee, is that appropriate to serve our patient population, everything like that. So that's something that we've been dealing with a lot, and we can help you with in terms of what your presentation should be and how thoroughly it needs to be discussed and reflected in your board minutes.
Right. Just to add to that, I would say that after Form 5A and credentialing, this is probably the next most issue where people get cited for. And to just expand on something Emily said, right? So previously, many FQHCs, you would have go back to your board once, let's say before the HRSA OSV, to have them approve that your nominal fee is of $15 is something that's not going to be a barrier to care. They want to see that, but now they also want to see for each of the other 3 categories, between 101 and 200%, that the board saw data about the usage in there, and the board approved the continuing discounts in each of those categories. And just saying the board approved the sliding fee will not work. They want to see actual data from each of those categories. We had 17 people in this category and 602 people in that category. And yes, we think that 25%, 35%, 45% is appropriate. By the way, it used to be in the past that you could have the same discount. You had 3 separate categories that have the same discount between 101 and 200%. That's no longer the case. It has to be different discount amounts. Also, you cannot give discounts above 200%. Absent having some other grant source, and if you have that, we can talk to you separately on offline about that. But if you have a policy that says anyone above 101%, or your last category goes up, the 175 to 1,000,000%, you cannot have that. It has to stop at 200%.
Okay, the next topic is quality assurance, quality improvement, quality assurance. This is a topic that differentiates FQHCs the most from private practices, because there is this major focus on providing totality of care to the patients as opposed to just episodic care. So there's a ton of documents and a ton of requirements that come with this. You need to have a QA policy, you need to have, plans, things like that. And a lot of what it addresses is listed out here. You need to address patient satisfaction. There's no specific way on how you need to address that, but it does need to be addressed. You need to address grievance process. There's a difference between, let's say, an informal grievance where, someone comes and says, I've been waiting for 40 minutes already, what's taking so long? So that's not something that would need to be written up, but if you have someone who comes and says, I really felt uncomfortable by the way this provider treated me, I'd like to write something up about it, your grievance process needs to speak about how it's going to be dealt with, and then that needs to actually be logged on a grievance chart. Another thing is that you need to have clinical policies in place. So it's impossible to have a clinical policy on every single situation that could arise. So a practical tip is that you have one paper that says we refer, we use UpToDate for our clinical policies, or we refer to ACOG or any of these like national standards, and then that's kind of giving you an umbrella coverage to make sure that you have a clinical policy that covers all of your clinical protocols.
Right. There's just something else about this is making sure that you have regular meetings and that gets reported to the board. Right. We have seen very often that what happens is you have tremendous quality departments and you're doing a lot of work and having regular meetings and really identifying issues. And then when you come to the board, you give a quarterly presentation that's 1 page long that just has, sort of 3 or 4 highlights of things that happened, which I'm not saying is inappropriate to do, but the board never gets to see the rest of what's done. So our recommendation is that besides giving that high-level presentation, you actually give the board the minutes of the QA committee and have them be attached to the board package. So, the board minutes going forward. I'm not saying you have to sit there and make them read it, but it has to be made available to them so we could include it in the board packages.
Right, and on that note, you also, a recommendation that we have is that you combine your QA committee and your risk management committee, because a lot of times health centers will start scrambling before their FTCA application is due because they don't have anything to show for risk management, and a lot of things overlap between QA and RM. So if you combine the two committees, then whatever you have presented and attached in your minutes for QA will also work to cover your risk management requirements.
I will just say that QA, our experience has generally been that FQHCs are very good at QA, but we've come across a couple that are not. And if you're not, the risk here is that the reviewer comes and thinks that your QA program stinks and then triggers an FTCA review, which, you know, for those of you who were on last week, we talked about the FTCA application and we talked a little bit about FTCA site review. That is a bear, right? That basically spending 2 days, instead of spending 2 days on 94 different things, they're spending 2 days on basically QA, risk management, and credentialing. So just be careful. Like, don't, I'm just going to pick an example. If you say, okay, we're going to do everything, but we're not going to do peer review, that's the kind of thing that could trigger it, right? We're going to do everything, but we're not going to have quarterly meetings. That could trigger an FTCA site review, which is not someplace you want to be. So make sure you're doing at least something for each of the categories within quality assurance.
Okay, very quickly, key management staff is essentially just your table of organization. It's pretty simple. You want to make sure that the operations are being run effectively. Historically, we've seen FQHCs are typically understaffed rather than overstaffed. So when you make your table of organization, make sure that you have the main, roles accounted for, and that also the way that it's laid out makes sense. So for example, you want to make sure that you're not having a clinical person report up to a non-clinical person, because obviously that's not okay. A trick that HRSA likes to do every time they come is to ask the board directly, who do you employ, who can you fire and hire? And there is only one correct answer to that, and that's the CEO. Everyone else falls under the purview of the CEO, but the board's one employee is the CEO. Okay, contracts and subawards pretty much just means if you're using federal grant money for procurement purposes. So these are highly, highly detailed and specific rules and regulations that get very complicated. So our biggest practical tip for this is if you're getting federal money, you should use it just to pay your employee salaries. Yes, you do still have to do time and effort reporting and be able to show that, but that's much easier to track than when you're buying things with that money, and then you have to have competitive bidding, 3 bids, things like that. There are some instances where you would have to use the grant money, like for a construction grant or something like that, and then it gets very specific and detailed. So if you have that sort of situation arise, you can contact us and we can help you figure out how to do it correctly and record everything correctly. Okay, conflict of interest pretty much says, am I buying something from someone who I have a relationship with? So obviously this comes up the most when it comes to the board. The board has to fill out annual disclosures and everything like that. But it's not only applicable to the board, it also is applying to key management staff and then really anyone who has to do with purchasing or procurement. So even if it's like someone all the way down on the food chain, it's someone who is involved in buying, you need to double check and make sure and make them fill out a conflict of interest that whoever they're buying from, they don't have a relationship with and they don't have conflicts. This is just, if you've heard us before, then you've heard us say this story, but we actually did have a client who we found out owned a laundry machine that the laundry service at the health center was using, and then it turns out not only did he own it, but he was charging the health center 3 times the rate of a standard laundry service. So this is something that comes up, and it's not that the board member could just, pro forma rubber stamp and sign the disclosure statement. You actually have to have them think about the question, have them answer it truthfully, check off the boxes, don't just sign at the bottom, make sure that annually those disclosures are filled out properly. Okay, collaborative relationships is something that HRSA didn't used to focus on so much. They're focusing on it more just in terms of checking that you actually do have papers that are memorializing your relationships with hospitals, other health centers, private providers, community stakeholders. So it can be very, very simple, 1-page letter saying like, yeah, we agree that we're going to work cooperatively to provide services to the service area. So just make sure you have things on file reflecting these relationships. Okay. Financial management and accounting systems. also could be, you know, a day's worth of work. But I will say that when we go into health centers, this is something that health centers feel very confident about. Yes, of course, we make sure that our, you know, our policies are airtight and we make sure our money is safe, and then we start to ask questions and things get a little tricky, and all of a sudden we ask them, how are you making sure that the money is getting from the patient's hands into the bank? And you think you have this perfect streamlined process, but it turns out there are many ways that money can slip through the cracks here and there. So if HRSA comes in and says, you know, is it possible for money to slip through the cracks? And you say, absolutely not, it's not possible, our money is super safe. That is a wrong answer, because it's actually impossible to create a system that is 100% foolproof. So our answer is, you know, we have so many safeguards in place. These are our safeguards. We try our hardest. We've never had an incident where money slipped through the cracks, but obviously, you know, it is possible. So an example of that, let's say, would be, you know, we ask you, how do you know that the patient cash is being recorded properly? And you say, oh, well, we give them a receipt, and then that receipt is documented in the file. But how many times do you go to a grocery store and actually check your receipt that what you got is what you're taking home? It's very possible that the person who's creating the receipt can say, you know, patient gave me $10 when in fact the patient gave $20, and the patient just never bothers to look at the receipt. So these are the kind of very minute issues that come up that can speak to much larger issues of not having fail-safe financial controls. So we review the policies, and then more important than the policies, we want to make sure that our procedures are matching the policies. You can have beautiful, perfect policies, and then the procedures have nothing to do with what you're actually doing.
Right, but I will say that this is one area where the policies, HRSA has required a number of changes over the last couple of years to this policy. So like I said before, if you have not updated this policy in the last 2 years, almost for sure there are going to need to be, you know, quite a number of changes. Not really substance changes, but language changes.
Right. And then another big issue, let's say, is like procurement or purchasing. You want to make sure that the person who is ordering is not the same person who's receiving, because you want to ensure that they're not, let's say, at September time ordering, you know, 10 extra notebooks and 5 extra cases of pens to give out to their students and student friends. So you want to always just make sure that you have controls and safeguards in place for where the money and the ordering is happening. Okay, billing and collections. Again, you just want to make sure that you're being careful with billing, depending on what your state requirements are. You're keeping records, things like that, being careful about how you're billing your wrap, everything like that. And also what's new is that they want to make sure you are having the board approve like your rates and your charges and your fees. That has to be reflected in the minutes. So make sure that you're doing that. Another thing is that they want to see policies for inability and refusal to pay. They want to see those as separate policies. So, you know, inability to pay, obviously we know what that is, but refusal to pay is something different. That someone walks in and says, you know, I know you're an FQHC and you have to serve me, so I'm never going to pay you, and you still have to serve me. You can have a policy that says, actually, no, we don't have to in that case, but that policy should be there, choosing one way or the other, whether you will serve that patient or you won't. Okay, budget, again, there needs to be an annual budget that's prepared, and then you want to just make sure that the board is, you know, apprised of that budget and how you got there. This sounds a little bit silly, but HRSA likes to see actual, like, pretty pictures and graphs shown to the board members to make sure that they're actually paying attention and understand what you're saying, because most people can't do numbers. So the pictures help ensure that they actually know what's going on. And yeah, you want to just show like year to date and the progress on the budget, and compare what your actual expenses are to what your budgeted costs were. Hey, UDS, this is, you know, fairly straightforward. You're collecting all this UDS information, and you want to make sure that it's being presented to the board. The measures are, you know, being paid attention to in terms of your QA activities and everything like that.
Right. So we just on that, we've heard of HRSA is starting a program where they're going to try to, I'll say, automatically suck the data out of your system without you having to send it to them, which is good for the people, right? And I always joke that in January and February you can't talk to anyone in the QA department and an FQHC because they're all busy with UDS, so that may make it a little bit easier. It makes it harder because it doesn't give you the ability to massage the data. So we will probably talk about that at a later time, but just something to point out there.
Yeah, sorry, we're rushing. We're just running out of time, so if you have additional questions, please feel free to send them. Board authority, so this is also somewhere where, like I said, the reviewers are kind of focusing more on minutes and being specific about what's being put into the minutes. It seems minor, but a lot of reviewers have brought up that they want to see not only who was in attendance, but who was excused versus, not excused from attending. There's also very specific language that needs to be included in the bylaws in terms of what their responsibilities are for the board. And
right, just on that also, right, we have seen there are some minutes that you have a meeting for an hour and you have 1 page of minutes, and there's some places you have minutes that are 65 pages long. Obviously, neither one of them is okay. And we've seen, unfortunately, people get dinged because for things they did but just didn't record appropriately. So if you need help, with a review of how to keep minutes, we're happy to assist you with that.
yeah, and then just another thing to mention is you need to make sure that you're having monthly meetings. So, with COVID, now everything is okay to be on Zoom, so that makes it easier, but just the practical tip is don't save your meeting until the last week of the month, because then in case you have, you don't have a quorum or there's some big snowstorm, you want to make sure that you have enough time to reschedule to still have it within that month. It's not enough to have, 2 meetings in December and then, 0 meetings in January. There needs to be 1 per month. Okay, board composition, this is something new that's come up. Obviously, we have all these requirements for the composition of the board, and it used to be that you just took your initial application when a board member joined, and that was enough, and that was all you needed to show. Now the reviewers are coming in and asking, well, this board member has been sitting on the board for 20 years. How do you know that they still live in the patient area or work in the patient area, that this is still their job, and that they still fulfill the requirements of the board composition rules? So we've created a tool which should be filled out annually, and pretty much what we do is we keep all of this information up to date. We have someone, go through this information, make sure that on an annual basis the board composition is, fulfilling its requirements.
So just to jump in, FTCA, we basically talked about this before. You need to have a process for dealing with any claims that come in. You need to have risk management, right? Make sure you have something on your website about it. Again, we said before, you really should be having joint QA and risk management meetings to cover all these things, and the patient tracking and all those kinds of things, right? We talked about this a lot last week on FTCA, so we're not going to spend much time on it now. Okay, as far as I'll say just a commercial for a minute, right? We could help you with all of these things. Like I mentioned earlier, we've helped them, participate in more than 50 overall, 15 in person, virtual ones. We have mock surveys that we do. We meet with you in advance. We can participate in the OSV. I'm not going to go through it now, but in the slides that will come out to you. And by the way, yes, we will send out the slides. Here's an example of what we do in a mock survey agenda. And here's just a list for you of documents that need to be updated. So as you can see, there's 29 different documents here. And within each of these documents, there could be many sort of sub-pieces that need to be updated. It's not necessarily just one change to it. We also do various trainings for the board and for FQHCs in general. I think we mentioned last week, we do risk management training as well for FTCA purposes. One last thing is we have a sister company that provides credentialing and privileging services. We've gotten many requests from FQHCs because they can't handle the credentialing process or can't do it efficiently, and so we have a sister company that performs those services. If you're interested, please reach out to us about it. Just to get some questions really quickly, we'll go over by a minute or two. Yes, we'll share the presentation. With regard to column 2 and column 3, there's a number of questions that came up. The way it works is column 2 means that you are paying for the service, and column 3 means that you're just referring it out. So you could, if for example, lab services, if you are both paying and just referring out, then you need both a contract that fits column 2 and column 3. If you're only referring out and not paying for it, then you only need column 3. Okay, other questions that came up is translators and interpreters. They do not need to be credentialed and privileged unless, well, if their sole responsibility is to be a translator or interpreter do not need to be credentialed. As Emily mentioned, you need to have column 2 language in the agreement with them, but you do not have to actually be credentialed and privileged. But if you're using a different staff member who happens to be a nurse and is translating, obviously they would need to be credentialed and privileged because of the nurse role. There's a question that was raised here, which is really an entire presentation in itself, about giving prompt pay discounts. I will tell you that prompt pay discounts used to be a very popular thing years ago when it took a long time for payers to pay you. Nowadays, when many payers pay within 10 days and at most within 30 days, it's very difficult to justify prompt pay discounts because you're otherwise getting paid pretty quickly anyway. I'm not saying it's impossible. If you want to call us and talk to us specifically about that, we're happy to talk to you about it. But the general, yes, I give a prompt pay discount is no longer the case. As far as other webinars, yes, we will be probably having additional webinars after the summer. If you have topics you're specifically interested in, please reach out and let us know, and we will try to address them. We probably will have one on human resources type issues and maybe on compliance, like fraud and abuse type issues. Thank you for joining us today in this webinar.